This is part 2 of our discussion of blood components. We're now going to talk about the non-red cell blood components. And the first one we're going to talk about is platelets. Platelets are used to prevent spontaneous bleeding or stop established bleeding in thrombocytopenic patients. So spontaneous bleeding can occur when your platelets get too low, or a patient may be thrombocytopenic due to chemotherapy or other situations. The platelets are prepared from a single unit of whole blood. So you do that soft spin to separate the red cells from the platelet-rich plasma, which is removed. Due to storage at room temperature, this is the most likely component to be contaminated with bacteria. Bacteria grow very well at room temperature. A therapeutic dose for adults is not this one little bag with about 30 to 45 cc's. It's 6 to 10 little bags or units of platelets. Some patients become refractory to platelet therapy because each unit represents a donor. So if you're transfusing a bag that has 10 units of platelets, those 10 units came from 10 different people. So by exposing the patient to all these different donors, some patients then become refractory. They will make antibodies to the platelets to where transfusions of random platelets no longer work. The expiration for platelets is 5 days as a single unit and 4 hours if pooled. I want to say this one more time. One little bag coming from one donor, the expiration is 5 days. Platelets, number one, don't live very long, and in storage, their activity rapidly decreases. If they're pooled together using that sterile docking device, it's 4 hours. So you need to know this, because when you make components, you will be trained how to change the expiration dates. These are stored at 20 to 24 degrees centigrade, which is room temperature, with constant agitation. We put them on this little shaker that it just very gently shakes them from side to side forever. If you leave a unit of platelets on the counter, they will aggregate. And it's very difficult to get them to come apart. They like each other so much, but in order to remove these aggregates, you just put them on the agitator for a certain period of time, and then you visually look and make sure that they have come apart. D-negative patients should be transfused with D-negative platelets due to the presence of a small number of red cells. Even though we've done this soft spin, we've separated the red cells, there's still going to be some red cells present in the plasma of the platelets. And remember, D-negative patients who lack the D antigen on their red cell, they're D-negative. When they're exposed to the D antigen, there is an extremely high likelihood that they will make antibodies to the D antigen, and we don't want to have that to happen. So the proper name of a unit of platelets made from one donor is a random donor platelet concentrate. One bag or unit from one donor. Again, it's prepared by centrifuging the whole blood with a soft spin. You remove the PRP. You centrifuge the PRP, remove the plasma except about 30 to 50 mLs, because we need to have plasma in there because that's the food and that has the nutrients for the platelets to survive. And again, 6 to 10 units is a therapeutic dose. It used to annoy me because at my hospital, they liked 12 units. And so they would say, oh, I want a 12-pack or I want a 6-pack of platelets. I don't know. Maybe they found it funny, but I did not. And again, we always talk about a therapeutic dose, not so much number of units. So this is a picture that illustrates the process. We have the red cells, the platelet-rich plasma, remove the plasma, and it leaves the platelet concentrate behind. So again, to pool platelets, we get a transfer bag, and there's two ways to do this. You can either use a sterile docking device to put the tubing together and then drain the platelets into the transfer bag, then seal it, remove it, and do the same thing with each additional random donor platelet, which is a much better way of doing it. It's much more sterile. Otherwise, what we do is we spike the random donor platelet, drain it into the transfer bag, then remove the spike, and very carefully, using aseptic technique, put it into the port of the next platelet. So I open the port of the next platelet prior to removing the spike so that I'm not fumbling around and perhaps touching that spike and getting bacteria into that transfer bag. Apheresis platelet concentrates have become very, very popular over the last 15 or so years. These are used to decrease donor exposure or to obtain HLA-matched platelets for patients who are refractory to random donor platelet concentrates, or to prevent platelet refractoriness from occurring to begin with. These are prepared by hemopheresis. One pheresed unit is equivalent to 5 to 6 random donor platelet concentrates. And so what we always tell the nursing or the doctor staff, that this apheresis platelet concentrate, which came from one person, is a therapeutic dose of platelets. And that's language that they, well, how many units is it equivalent to? It's a therapeutic dose. It's stored at 20 to 24 degrees centigrade room temperature with agitation for 5 days. And again, D-negative patients should be transfused with D-negative platelets if at all possible. Apheresis is a process by which we hook a donor up to a machine and take their blood, and it goes into a chamber, and then it's separated out to where we get the one component that we want. In this case, we're talking about platelets, so you can see the platelet-rich plasma. And the machine is able to determine, okay, we're moving the plasma layer here, then we remove the platelets over here, and then the red cells back over here with the plasma, and those components will be returned to the donor because all we want is their platelets. So this is an illustration of a donor being apheresed. And if you've heard of plasma centers, this machine is also used there because they will use the plasma for pharmaceutical manufacturing. But again, all components that are not needed are returned to the donor. So to summarize, apheresis single donor platelet concentrates is a bag or a unit that comes from one donor. 1 unit of apheresis platelets is considered a therapeutic dose, and the volume is pretty large. It's about 250 cc's. The next blood product we're going to talk about is granulocytes, and this is just your little reminder for hematology, and I want you to know that you cannot compartmentalize yourself. I'm just working blood bank, that's all I'm thinking about. I'm just working hematology, that's all I'm thinking about. If you have a patient in hematology that comes through with a 4-gram hemoglobin, you better let the transfusion service know right away, because a lot of what's done in hematology impacts my job in the transfusion service. This is the first time I've been able to find pictures of granulocyte concentrates. So the picture on the left, the white arrow indicates the granulocyte layer, and the red arrow indicates the red cell layer. This is a very bloody product because they spin it down and they harvest the buffy coat. Well, the buffy coat isn't real big, and it's very difficult to get the buffy coat without contaminating it with red cells. And the picture on the right illustrates the granulocyte product with 30 mL of red cells that's been mixed up. It almost looks like a unit of blood. The primary use of granulocytes is for patients with neutropenia. What does that mean? That means the neutrophils are decreased, who have gram-negative infections that are documented by culture but are unresponsive to antibiotics. Therapeutic efficacy and indications for granulocyte transfusions are still not well defined. I did a quick search of the literature. The donors are given granulocyte colony stimulating factor to mobilize the neutrophils into the peripheral blood. Better antimicrobial agents and the use of apheresis granulocytes transfusions demonstrate some success. The best success with this component has been with babies. And it's a situation in which the patient's going to die because they have this overwhelming sepsis and it's not responding to medications or antibiotics. So what is the harm in trying to save their life by giving a granulocyte transfusion? Once started, granulocyte transfusions must be given daily. They are prepared by hemopheresis, similar to the process that we remove platelets. This product must be irradiated prior to transfusion to prevent graft versus host disease. And again, we'll talk about GVHD in detail later on in this course. The expiration time is 24 hours, but it's best to infuse ASAP. As soon as that product arrives, then you need to give it. And the difficulty lies in getting all the testing done. But what they do, which is kind of ingenious, is they have the potential donor come in a couple days ahead of time. They draw their blood, they do all the infectious disease testing and tell them, behave yourself. And then when they come back, they can go ahead and donate the product, which takes a couple of hours, and then they can send it over for transfusion. This product is stored at room temperature, 20 to 24 degrees. Now we're going to move on to plasma components. Fresh frozen plasma, pooled plasma / solvent detergent treated, and cryoprecipitate. Fresh frozen plasma, most commonly known as FFP, is used to replace the labile and non-labile coagulation factors in massively bleeding patients, or to treat bleeding associated with clotting factor deficiencies when a factor concentrate is not available. So you need to bring coag back to the front of your brain. Which of the factors are labile? Which of the ones are non-labile? And what is meant by labile? This product must be frozen within 8 hours of collection. The volume is about 200 to 250 cc's, and the expiration date is based on the storage temp and or the condition. If it's frozen and it's stored at -18 degrees, it's good for 1 year. If it's frozen and it's stored at -65 degrees, it's good for 7 years. And once you thaw it, it's only good for 24 hours. So this slide has a reminder about the storage temperatures for FFP. So what do you do with it? How can you prepare it for transfusion into a patient? Well, you have to thaw it out. So you take it out of the freezer and you put it in a 30 to 37 degree water bath that's designed to thaw FFP, or an FDA approved microwave, which I've never had the opportunity to use, but that sounds delightful. So on the right hand side of this picture, it shows a FFP thawer. So you stick it in those metal baskets, one on each side, so a total of 4 units, and then you pop it down and it will agitate the water to where it will enhance the thawing of the FFP. When storing FFP, you have to have a mechanism to detect units which have thawed and refrozen due to improper storage. So what they'll do is they'll intentionally have a bend or a divot in the bag by putting something there to make an impression. And when you take the FFP out of the freezer, first thing you look at and make sure that divot or that indentation is still there. This must be ABO compatible. So the universal donor for plasma is AB. Group AB people do not have anti-A and they do not have anti-B in their plasma. The most recently licensed product is pooled plasma / solvent detergent treated plasma. This product is prepared from pools of no more than 2,500 units of ABO-specific plasma, which is frozen to preserve the labile coagulation factors. It's treated with chemicals to inactivate lipid envelope viruses, and it contains both labile and non-labile coagulation factors. But it lacks the largest von Willebrand's factors, multimers. It's used the same as FFP, and the safety concerns, one good safety concern is it does decrease disease transmission for the diseases tested for. It Bad news is it doesn't inactivate virus with non-lipid envelopes. For example, parvovirus B19, hepatitis A, which that's transmitted through the fecal-oral route, and unrecognized pathogens. Cryoprecipitate antihemophilic factor, also known as AHF, but we usually just call it cryo, is the cold, insoluble portion of plasma that precipitates when FFP is thawed at 1 to 6 degrees. So what you do is you take a unit of plasma, and this is done at the donor center. You put it at 1 to 4 degrees, and as it thaws out, a insoluble precipitate will form. And I can't recall how long it takes for this process to occur. So what they have found that this cryoprecipitate contains very high levels of factor VIII and fibrinogen. And this is used for treatment of hemophiliacs and von Willebrand's disease when those specific factor concentrates are not available. It's used most commonly for patients with disseminated intravascular coagulation or low fibrinogen levels. A therapeutic dose for an adult is 6 to 10 units. And what was really sad is when HIV first came out and they lied to us and said, oh, it's not transmitted through blood products, and we found out it was. Over 50% of the children or even patients with hemophilia became HIV positive because that was the process. 2,500 donor units, and they thaw them and they create this product and then they lyophilize it. And fortunately, that process did not kill HIV. So it was devastating to that particular community. Cryo can be prepared from whole blood, which is then designated as whole blood cryoprecipitate removed, or from FFP. So again, I told you the plasma is frozen, is thawed, the precipitate forms, which is insoluble, meaning if you shake, it's not going to go back into solution. You centrifuge it, the cryo goes to the bottom, you remove the plasma, and you must freeze it within 1 hour of preparation. This picture nicely illustrates the preparation of cryo. So we have FFP that's frozen within 8 hours. It's thawed at 1 to 6 degrees centigrade and insoluble precipitate forms. We spin it down, remove the plasma, freeze the cryo. In order to use it, we have to thaw the cryo at 30 to 37 degrees. So we can use the FFP thawer. And then you store it at room temperature, and it's only good for 4 hours. That's why we have to have an order for SureGive. We are definitely giving this product. It's not, we might give it, or maybe we'll need it tomorrow. No, you need to let us know when you need the product. And there's only like 15, at the most 30 cc, so it thaws out very, very quickly. So they made a change to the standards of storing cryo that it needed to be stored in the refrigerator. And I'm like, oh my goodness, I don't understand. I don't understand. And this went on for a couple of years. And then somebody did a study, and they found that when they had this cryo that was stored in the refrigerator and they put it through a filter, it removed a lot of the factor VIII and the von Willebrand's factor. So the pendulum swung back, and now we store it at room temperature. The plasma cryoprecipitate reduced is refrozen within 24 hours of separation, and it's good for 1 year when it's stored at less than 18 degrees. If you thaw it and stored at 1 to 6 degrees, it has a 5-day expiration. So this isn't FFP. This is plasma that the cryo and the von Willebrands have been removed. So it has, because this will be used for a different purpose than regular fresh frozen plasma. So cryo has a volume of less than 15 mLs per unit. This is a picture of a unit of cryo. It doesn't do it justice because the volume is so small. This almost looks like FFP. Storage, frozen -18, thawed at room temperature. The expiration is when it's frozen, it's good for 1 year, thawed 6 hours. And once you pool it, it's only good for 4 hours. It's best to be ABO compatible, but really in the big picture it's not important due to the small volume. So you have 6 units, that's 90 cc's. In the big picture, think of a graduated cylinder, 90 cc's. It's not much. Irradiation of blood components is a very commonly performed procedure on components. Cellular blood components are irradiated to destroy the viable T lymphocytes. Remember, that's part of your cell-mediated immunity, which may cause graft versus host disease. GVHD is a disease that results when immunocompetent, viable lymphocytes in the donor blood engraft in an immunocompromised host. They then multiply and they start looking around and they say, this is not my body. These tissues are foreign. And so these engrafted lymphocytes from the donor start producing antibodies against the patient tissues, primarily the skin, the liver, and the GI tract. The resulting disease has serious consequences, including death. GVHD may be chronic or acute. Irradiated blood components should be used for patients who are at the highest risk of getting GVHD. The severely immunosuppressed, and I've said this before, transplant patients, that they are put on heavy-duty immunosuppressive drugs for the rest of their life. Immunocompromised, those individuals receiving blood that was donated by relatives, which, it's really not a good idea to do because there's too much genetic similarity between you and your siblings or even aunts and uncles. Irradiated blood should also be given to fetuses receiving intrauterine transfusions. And we'll talk about this procedure in detail later on in the semester. It's really mind-boggling. Irradiation inactivates the lymphocytes, leaving the platelets, the red cells, and the granulocytes relatively undamaged. The donor unit must be labeled irradiated, and the expiration date of the red cell donor unit changes to 28 days or the original expiration date, whichever comes first. If these are not used, they may be transfused to normal patients without any ill effects. So those blood centers or transfusion services that have an irradiator, they have to keep it under lock and key because it has radioactive components that can be used to make a dirty bomb. So all facilities now have to have limited access to the blood irradiator. So once they put the units in, it's exposed to a certain amount of irradiation for a certain amount of time. How do you know it's done or it's worked? Well, you put this special sticker on it before you put it in the radiator, and if it says not irradiated, well, you know what that means. And if the not is blacked out, that means it has been successfully irradiated. Well, now that we've talked about all the components that I want you to know everything about, we're going to talk about donor blood inspection and disposition. It is required that donor units be inspected periodically during storage and prior to issuing to a patient. The following may indicate an unacceptable unit: a red cell mass that looks purple or clots that are visible. Clots in the unit will look blackish. A zone of hemolysis observed just above the red cell mass, or look for hemolysis in sprigs. This is the tubing that comes off of the red cell unit, and it's divided into little separate segments, and especially those closest to the unit. That could be an indication of a special bacteria that can live and grow in donor blood. If the plasma or supernatant plasma appears murky, purple, brown, or red, you would want to quarantine it and then make a determination as to whether or not to reject it. A greenish hue need not cause a unit to be rejected, and we're specifically talking about plasma or platelets because this can be due to birth control. You want to inspect platelets for aggregates, so we take it out of the rocker and we actually look at it to make sure that there's not platelets that have clumped together. You want to inspect FFP and cryo for signs of thawing, evidence of cracks in the bag, or unusual turbidity in cryo or FFP. for example, extreme lipemia. So this was observed as a indication in donor units that it may be contaminated with bacteria. If you look at this sprig that is closest to the donor unit, you notice that it's hemolyzed, and the red cells look a little bit more blackish than normal. And so you would definitely want to put this unit on quarantine and perhaps go ahead and enter it and culture it. But to be on the safe side, this donor unit would probably be destroyed. So if a unit's appearance looks questionable, do the following. We go ahead and quarantine the unit until disposition is decided. So you gently mix, then allow it to settle, and then observe the appearance. And we have little holders that the blood can sit in to where we can actually see how it separates out. If bacterial contamination is suspected, the unit should be cultured and a gram stain performed. Positive blood cultures are usually indicative of inadequate donor arm preparation, improper pooling technique, or the health of the donor. Perhaps the donor had bacteremia and was not showing symptoms right away. And that's why we ask the donor to call us if 24, 42, 72 hours later they have signs and symptoms of an infection, because we'll want to pool that donor unit. An inadequate donor arm preparation isn't as much of an issue anymore, since we now have that little bag that the plug of skin goes into. If one component is contaminated, other components prepared from the same donor unit may be contaminated. And that's when we look at our look back process and we figure out where these donor units are. The plasma, the platelet, because many times each component is sent to a different hospital. So let's say that a donor unit was issued for transfusion, and for whatever reason the patient's IV blew or other issues, they could not transfuse it, and they bring it back to the transfusion service. Reissuing that donor unit cannot be done unless the following criteria is met. The container closure must not have been penetrated or entered in any manner. They can't spike the unit of blood and then bring it back. Most facilities set a 30-minute time limit for accepting units back. Warming above 6 to 10 degrees centigrade, even with subsequent cooling, increases red cell metabolism, which can result in the production of hemolysis and permitting bacterial growth. Blood must have been kept at the appropriate temperature. One sealed segment must remain attached to the container, and records must indicate that blood has been reissued and inspected prior to reissue. So every unit of blood, we now use a scanner to scan the barcodes, and we can easily track how many times this donor unit was cross-matched and issued and brought back. Platelets may be accepted after 30 minutes if the platelets still swirl and there's no visible clumps. And you have to put it back on the platelet agitator for at least 10 minutes to ensure that the platelets are not clumping. Transportation of blood and blood components, you're not going to be stunned or amazed. A shipping container used for transportation must be validated to ensure proper temperature is maintained, and the most popular container is an Igloo ice chest. Yeah, an Igloo ice chest. And so again, we do QC, we go ahead and put donor units in, set a timer for 30 minutes, and make sure that the temperature is adequate. Place different numbers of units to transport in the container with a coolant, and they usually use ice, and we don't put ice directly in contact with the donor unit because that could cause hemolysis. What we do is we have the ice, and then we have a layer of material, and the donor unit goes on top. You want to measure the temperature frequently to determine the maximum number of units which can be transported at one time and maintain temperature. The most common reason that we transport multiple units is usually to the OR when they expect a really bloody surgery, that they need the blood really fast and they want to have it in the operating room. So whole blood and RBC, a sturdy, well-insulated cardboard or styrofoam container can be used. wet ice in a Ziploc bag or packaged coolant to cool, and the temperature must be monitored. We make our nurses monitor it every 30 minutes when it's out on the floor or in the OR. Getting compliance with this is kind of difficult. Much blood has been wasted because if the temperature is not monitored, if it's not written, it's not done. So we have no choice but to dispose of that blood. Mobile collection units should transport blood ASAP or leave it at room temperature if platelets are to be made. In-house transport, place in the cooler with wet ice or packaged coolant and a thermometer, and check that temperature every 30 minutes. Unfortunately, we have come to distrust medical staff who take our blood away, and they promise that they're going to monitor the temperature, but unfortunately it doesn't. So this is called Safety View Temperature Monitor. When the blood gets above 10 degrees Celsius, the little button will turn red, and that means you cannot accept that unit of blood back into inventory. So, summary of transportation of blood and blood components. Frozen components, the temperature must be maintained at or below the required storage temperature. Use dry ice in a well-insulated container if it must be transported. Platelets and granulocytes maintain at 20 to 24 degrees centigrade, which is room temperature. The reason I keep saying that is it needs to become second nature to you that 1 to 6 degrees is refrigerator, 20 to 24 degrees is room temperature, and minus 18 degrees is your freezers. The platelets and granulocytes are transported in a well-insulated container without ice because we want them to be at room temperature. Commercial coolers are available to maintain this temperature. Handling donor units. Donor units should not remain at room temperature unnecessarily. When blood is issued, it should be transfused as soon as possible. I could tell you story after story after story I've heard about the inappropriate handling of donor units by nursing staff, and it's they're ignorant. If you remember, I think I've told you this before. Ignorant is you do something and you don't know any better. Stupid is you've been told it's wrong and you do it anyway. And most nursing staff, they're ignorant. They weren't trained in laboratory medicine. So it's up to us to constantly remind them gently that be sure that this blood is transfused as soon as possible. When numerous units are removed from the refrigerator, you want to remove a filled container with a thermometer at the same time as the blood. When the temperature reaches 6 degrees, return to the fridge. He said, why would you do that? Well, the donor center will bring over 30, 40 units of blood. We're a big transfusion service. And so we need to process that. We need to enter it into our inventory. And the best way to do that is we bring out quite a few units and we barcode them and do all our work, and then we return them to the refrigerator. So again, by doing this, you can make sure that you're processing quickly enough to maintain the required temperature. Component records must be made concurrently with each step of component preparation, being as detailed as possible for clear understanding. The record must be legible and indelible, meaning you have to use waterproof ink, must include the dates of the various steps and the person responsible. So the donor center will have their records, and on the transfusion service, when we thaw out cryo, when we pool cryo, we need to document each step. And there's a special label for the final product, and that varies depending upon what the product is. I believe I put this link in your resources or references. You must bookmark the blood bank guy. He has been around for a long, long time, and his presentations and his notes, and they're just incredible. And they bring the knowledge down to your level. And it's designed not just for MLS and MLT students, but actually for physicians as well. He has podcasts, he has videos, glossary, quizzes. Be sure and do the quizzes. There's not very many. I wish he would make more, but they give you have to go, there are about 15 questions, but then not only does it tell you that you got it wrong, but why you got it wrong, which I always like when you have these practice quizzes. And you need to read the questions carefully. I got a question wrong because I went too fast. I was in too much of a hurry. But these are excellent ways to test some basic knowledge. The University of Texas Medical Branch at Galveston, their website is also incredible. So again, sometimes the way I say things may not make sense, and you hear somebody else give the same exact presentation but use slightly different wording, and then you get it. This is the end of part 2 of components.